Kia ora koutou katoa. Welcome everyone from around the motu. Ko Andrea Ting, tōku ingoa. I'm Senior Research Fellow, University of Otago, Wellington, chairing today, and I'm going to introduce our speaker shortly. I'm one of the members and many of the Virtual Health Information Network executive, and Gabrielle Davie speaking today is another member on the VHIN, and many of you already know about the VHIN, but obviously we're keen to support users of the IDI and linked up data, and yeah, we've been going for a few years, and so recently, this is I think only the third. This is our November webinar, and we're really excited to have Gabrielle Davie come and present to us. So let's introduce Gabrielle Davie. She is an associate professor and a biostatistician at University of Otago, based in Dunedin, and she has many years of experience and diverse experience and expertise, particularly around the routine health data and linked health data. So she is going to bring and share some of that with us today. I guess two main topic areas that Gabrielle's been working in. One's around injury prevention, and the one she's going to talk to today is around rurality and the intersection with deprivation and ethnicity, and rural urban classification, so geoclassifications for health. So we're really looking forward to this. I have heard good things about this presentation, so I'm looking forward to hearing from you too, Gabrielle. And yeah, I think that's all I wanted to say. So all over to you, Gabrielle, and thank you so much for doing this presentation today. Thank you.
Oh, good. Thanks, Andrea. I guess to start with, I want to acknowledge the research team that's involved with this research. So Gary Nixon has been the principal investigator or co-PI of this body of work that will be presented today. He's the Associate Dean Rural here at the University of Otago, and based in Clyde. Professor Sue Kringle is our Senior Māori investigator, and the rest of the core team is listed sort of vertically on the slide, and then horizontally is a range of other named investigators that are involved in different projects that we have underway. And the Zoom icon there is just because that is the way that rural health researchers typically work, is via Zoom with important face-to-face meetings where possible. In terms of the projects that have informed the research to date, there are four main projects that I've been involved in that I'm going to present on today, and just specifically with this slide, want to acknowledge the range of funders for the research that we've been able to undertake. So in terms of a bit of a roadmap for this presentation, bit of background, then I'll explain what the GCH is, the Geographical Classification for Health, then look at what difference it makes. I'll present some research findings. I'll discuss how to access and utilise the GCH, a little bit about some research that's recently got underway, and where we're heading with that, followed by a conclusion. So in 2010, in a report titled Rural Health, Challenges of Distance, Opportunities for Innovation by New Zealand's National Health Committee, the executive summary stated, in considering the health of rural communities, the NHC found that life expectancy and other measures of health status are similar for rural and urban populations overall. Interestingly, this was in contrast with both New Zealanders working in health research on the ground thought was the case, and also what was happening, what had been determined in Australia with some of their research there, where there were clear patterns of avoidable deaths and chronic disease mortality that increased as rurality increased. Both of those outcomes were lower in major cities and had occurred at higher rates in more rural and remote areas. So this got people questioning what was going on. So over the next few years, there was a range of inconsistent findings around inequities in health outcomes for people that lived in rural and urban areas. And a major barrier has been the absence of an agreed definition of rural. And because of that, a range of different definitions of rural have been used, which makes understanding the literature and what's happening complicated. In mid-2021, the proposively designed Geographic Classification for Health was published. So what is the GCH? Well, I guess first I want to acknowledge that what rural is in New Zealand does vary, as you can see from these images, but also I guess your own mental images of what rural means to you. There are definitely similarities between rural areas, but there's also considerable variation. And I just noticed in these photos, it's clearly always sunny and it's blue sky days in rural areas. The GCH was developed not as an accessibility classification, not as a funding formula, but as a rural-urban geographic classification that can be used to accurately monitor rural-urban variations in health outcomes. We want it to be used to inform decision-making and to be used in combination with other data sets. I'm not going to go into the development of the GCH in this presentation. There have been a number of presentations already on that topic, but if you are interested, here's the journal article in which we describe in detail the process that we use to obtain this classification. And here are the maps that show the GCH, and this is using the Census 2018 data. Ideally, we'll be able to update the GCH using Census 2023. In terms of describing the GCH, so we've got 5 categories, U1 being the most urban category, which you can probably tell from the maps there. U2 is more the provincial cities, so urban, but not your major metropolitan areas. And then 3 categories of increasing remoteness, from R1 being through to R3, with R3 being the most remote areas. And as you can see geographically, R3 is the largest, but as you'll probably guess, that doesn't reflect in terms of the population. So describing that a bit more, the usually resident population using the 2018 census, 63% of our New Zealand's population live in U1, 18% in U2, and then sort of 12, 6 and 1% in the rural categories. This that table there also indicates that although the GCH has been developed with 5 categories, we acknowledge that for some research, urban-rural comparisons using a binary level measure might be necessary. And so that's possible as well. In terms of the distribution of the population for Māori and non-Māori by GCH, you can see from this slide that there are quite substantial differences in the population distribution, with considerably less Māori living in U1 areas and more Māori living in rural and remote areas than non-Māori. So what difference does using the GCH make? So going back to what the NHC said in their report, that the measures of health status were similar for rural and urban populations, we wanted to know whether that was true if you use the GCH. So we compared mortality rates, all cause specific, and amenable mortality, which refers to premature deaths that could potentially be avoided given effective and timely healthcare, between the GCH, the UREP, which is Stats New Zealand's 2004 Urban Rural Experimental Profile, and Stats NZ's 2018 UA are their urban accessibility classification. So we're looking at age sex adjusted incident rate ratios. So for estimates that we've got on the left, that's where of the dotted line, that's where the rural rate is less than the urban rate, and the converse on the other side. So using the UREP, we find that for all outcomes measured there, the age sex adjusted incident rate ratio is lower if we use the UREP, lower in rural areas than it is in urban areas for the UREP for all outcomes apart from injury. A similar pattern but less obvious was obtained using the UA, the Stats NZ's urban accessibility classification, but still we see that rural rates are less than urban rates for all measures outcomes here apart from injury. Using the GCH, a different pattern is observed with rural rates being higher, rural mortality rates being higher than urban mortality rates. So you can see that using the GCH makes a substantial difference. Now, the thing to point out here is that the Stats New Zealand classifications are generic classifications, whereas the GCH has been designed specifically for use in health research and health policy, informing health policy. This publication goes into more detail about the comparisons between the different rurality classifications if you're interested in finding out more about that. I'm now going to talk about 4 areas that we've focused on recently in our research. The first is the extent of rural-urban differences by age. Apologies if you can hear the drilling in the background. Nothing I can do about it. Earlier this morning, we did have a fire alarm. Fingers crossed that's not going to happen during this. So looking at rural-urban differences by age, we looked at mortality to start with, and that's by cause and cause-specific. And again, here's a publication if you want to find out more of the details. Here, looking at all-cause mortality and using 15-year age groups, we compared all-cause mortality rates between the 5 GCH categories using U1 as the major metropolitan areas as the reference group. So looking first at the rural all-cause mortality, we can see that in those aged under 30, the all-cause mortality rate for those living in R3, the most remote areas, is double that of U1. For R1 and R2 areas, for those people living in those areas, this estimate is roughly 50% higher. Interestingly, these differences are smaller in older age groups, with no urban-rural difference apparent for those in the 60 to 74-year-old age group, and a different pattern again for those aged 75 or over. When we add the rates for U2 onto the graph, we can see that residents of the provincial cities have higher mortality rates than the U1 residents for all age groups, falling sort of in the middle of the rural categories. We also looked at the utilisation of publicly funded healthcare services by age. This included a range of outcomes from the National Minimum Dataset, including all-cause, cause-specific and ambulatory sensitive hospitalisations, and from the National Non-Admitted Patient Collection, specialist outpatient ED, allied health and total consultations. A revised article to a journal is being resubmitted today, so I don't have a publication to give you for that one, but get in touch in a few weeks, hopefully, if you do want to find out more details about this particular piece of work. So looking first at the all-cause hospitalisations, you can get your first clue that there's a different pattern than what we saw for mortality, because the reference line on this figure is higher. We found that U2 residents had a higher all-cause hospitalisation rate for all age groups, but particularly for the 50 to 29-year-old age group. The same pattern with a peak for the 15 to 29-year-olds was observed when rates for those living in the rural categories were compared to U1. Apart from for the 15 to 29-year-old age group, rates of all-cause hospitalisation are lower for those living in rural areas compared to those in U1, particularly for those living in R3, the most remote areas. Ambulatory sensitive hospitalisations are defined as hospitalisations of people less than 75 years of age resulting from diseases sensitive to prophylactic or therapeutic interventions that are deliverable in a primary healthcare setting. As you can see from the pattern observed here, there were higher ASH rates for those in U2 compared to U1, particularly for 15 to 29-year-olds again, and lower rates for those in rural areas compared to U1. The second set of research findings that I'm going to present today had as its aim to describe the impact of living rurally on Māori mortality. Again, here's a publication if you want more details, and do feel free to email me after the presentation too if you want a list with links for the publications. Here are the age-sex standardised mortality rates for Māori and non-Māori by the GCH category. So working top down are the all-cause mortality rates for Māori in the dark blue, then the all-cause for non-Māori, with the lower two lines presenting the amenable mortality rates, the rate for Māori in orange and non-Māori in yellow. From this, the most obvious rural-urban disparity is apparent for the all-cause mortality for Māori. In using relative differences to compare these rates, we can see that compared to non-Māori, Māori have at least 80% higher all-cause mortality rates in all strata of the GCH, but the disparity is particularly apparent in R3, the remote areas, where the age-sex standardised all-cause mortality rate for Māori is 2.3 times that of non-Māori. When we look at the impact of rurality for Māori, we see a trend for increasing all-cause mortality with increasing rurality. Compared to those living in U1, there was a 10% higher mortality estimated for residents in U2 and 21% higher for those living in R3. The amenable mortality Māori non-Māori rate ratio show that in all 5 levels of the GCH, Māori mortality is over twice that of non-Māori. Evidence of a gradient in Māori non-Māori inequity and amenable mortality as rurality increases is less convincing than for all-cause mortality. Sadly, there's been little change in the amenable mortality inequities since the Taiwhenua Health of Rural Māori report, which used mortality data from 2004 to 2008. And it's particularly given amenable mortality is that which could be prevented with access to high quality care. When we look at the impact of rurality for Māori, we see a similar trend for higher amenable mortality rates in more rural areas as we did for all-cause mortality. Compared to those living in the most urban areas, there was about a 10% higher mortality rate for residents in U2 and R1, and 37% higher rates for those living in the R3, the most remote areas. Another area of research that we've undertaken is looking at the intersection and intersection of rurality, deprivation and ethnicity, and the impact of these on mortality. Rural-urban differences are often conflated with differences in the ethnic and socio-economic composition of rural and urban areas, and understanding this interplay is obviously crucial for designing and targeting health interventions for people who live in rural New Zealand, and it's of particular importance to Māori. Here we have a heat map providing row percentages by GCH category for Māori and non-Māori separately. We've got the NZ-DEP quintiles along the bottom. For those unfamiliar with NZ-DEP, Q1 indicates areas with lowest socio-economic deprivation, and Q5 the 20% of areas with the highest socio-economic deprivation. The colour coding indicates the percentage of the usually resident population in that GCH category, with darker shading indicating a higher percentage of the population. In all GCH strata, a noticeably higher proportion of Māori live in Q5, the most deprived areas, compared to non-Māori, and this increases markedly for those living in more rural areas. For Māori living in U1, 37% live in the most socio-economically deprived areas. In R3, the most remote areas, this is 73%. For non-Māori, the respective percentages are 16 and 22%. We obtained age-sex standardised amenable mortality rates for each GCH NZ category, and rate ratios were used to compare these combinations of categories with the lowest rate. So the lowest rate of amenable mortality was observed for non-Māori living in the most urban and the least deprived areas. For non-Māori, amenable mortality rates for those living in Q5, the most deprived areas in any urban rural category, were roughly twice as high as for the reference group, so non-Māori living in U1 Q1. For Māori, amenable mortality rates for those living in the most deprived areas in any urban rural category were about 4 times as high as the reference group. There was some evidence of age-sex standardised amenable mortality rates increasing as rurality increased, although this pattern was not as marked as that observed deprivation. The last project I'm going to present is He Auraka Uruta, which was a mixed methods project with a focus on what we could learn from factors underpinning the rollout of the COVID-19 vaccination program and the pandemic response in different rural communities. This figure shows the national uptake of the second dose of the COVID-19 vaccination by fortnight over the peak vaccination period, which was June to December 2021 by GCH. As you can see, uptake was similar in all GCH strata until about fortnight 6, and then the rates diverge until fortnight 6, and then the rates diverge more noticeably. At the end of this period, the order aligns with the GCH groupings, with the vaccination rates higher in U1, decreasing through the GCH strata, so with the lowest rates of vaccination uptake observed in R3. Interestingly, different patterns are apparent by ethnicity. Here, the top figure presents the relative rates, again with U1 as the reference. For a period early in the rollout, Māori living in R3 had higher rates of vaccination than Māori living in U1, the most urban areas. Understanding what worked well for rural populations is part of the qualitative arm of this project. For non-Māori, rural populations had noticeably lower relative vaccination rates throughout the period, although, as you can see from the lower figure, this disparity did reduce considerably by the end of 2021. Now, for those that are wondering about how to find and use the GCH, those who have experience using NZDEP will find using the GCH very similar. We have a range of concordance files available on our blog. Which file you need depends on what geographical information you have in your data set. The GCH was defined using SA1, Stats New Zealand Statistical Area 1s. So we would recommend using this geography if you can. The SA2 concordance file aggregates the SA1 level information, some includes more averaging. The mesh block level data is not mesh block specific. It has the same GCH value for all mesh blocks within an SA1. And for those who use health data sets, there is a domicile level concordance, but that does include some population weighted averaging to obtain domicile level information. So if you're using administrative data that's already been collected, we recommend to request the smallest geographical unit that's available to get the most precision. The GCH can also be applied to non-administrative data. If you have addresses, they can be geocoded to a geographical unit. There's software available, but if you want advice, contact my colleague and the data management expert on this project, Brandon de Graaf, whose details are there. I also should have mentioned earlier that discussions have started to get the GCH into the IDI, and we realise we should be progressing that. I also want to point out that the GCH can be applied to any New Zealand address. It doesn't have to be a residential address. So myself and colleagues have used the GCH to obtain the rurality of the location of injury, because obviously that's relevant from a number of aspects, including emergency medical services. In terms of research that we're currently working on, we obtained funding for a project that started towards the end of last year on understanding the impact of rurality on health outcomes and healthcare delivery. This research will address 3 areas that consultation with the rural healthcare community highlighted as crucial to informing equitable and cost-effective rural health policy and service delivery. The overarching objective of this research is to obtain a more accurate understanding of the health status, healthcare needs, and healthcare consumption of New Zealand's rural populations and how they differ to that of urban populations. As part of it, we will be extending the earlier work that I described on the intersection and impact of ethnicity, deprivation, and rurality. So we'll be considering Pacifica populations and also extending the outcomes to wider than all-cause and amenable mortality. And we're using a structured consensus process to obtain health outcomes of interest. The second question that's part of that project is looking at the extent to which rural-urban relocation occurs in the last 5 years of life, especially for Māori. So healthcare planners often assume that individuals move closer to urban healthcare services in the latter years of life, whereas rural healthcare workers report that Māori often return home to rural areas in later areas of life. Per person health system utilisation and costs in the last year of life are estimated to be 10 times the average cost for the previous years. So obviously this is important from a financial aspect. And identifying the pre-mortality patterns of this rural-urban relocation is critical to understanding population health needs and informing health system planning. So as part of this, we want to find out if the lower rural mortality rates in the later years of life are due to a healthier elderly rural population or whether they're an artefact resulting from migration. If older rural people are finding themselves forced to migrate closer to services when they become unwell and frail, we need to reconsider the provision of these services in rural areas. The third research question is understanding getting an estimate for the urban-rural variation in total public healthcare consumption and costs. International evidence indicates that rural communities use fewer resources than urban counterparts, despite having higher needs. These consumption differences are also due to barriers for rural populations or privileges that urban populations experience in accessing specialist services. Taking a macro-level health economics approach and quantifying the healthcare consumption in dollar terms has advantages over considering service utilisation alone. In terms of comparing the methods that we're using for these 3 research questions, some of the questions are being undertaken or will be undertaken in Stats New Zealand's Integrated Data Infrastructure, the IDI. Other questions are able to be answered using routinely collected health data that's available outside of the IDI. Research question 1 in particular, we use as the denominator the aggregates from the census and numerators typically from the Ministry of Health. Research question 2 will be identifying a study-specific cohort in the IDI. And in research question 3, we're using Ministry of Health datasets with the health service use a population as the denominator and an NHI-linked numerator. So a range of methods appropriate for the questions that are being asked. In terms of denominators, I just want to draw your attention to this article that was published at the end of last year that raises, or some would say continues to raise, the issue of undercounting and underrepresentation of Māori in the health and disability data. And this is something that we are aware of and that does need to be addressed. In terms of denominator options, both within the IDI and outside the IDI, there are obviously a range of different denominator options. It's important to understand and acknowledge the strengths and weaknesses of any chosen approach. And I would recommend that you do that in any research that you're undertaking, but also be cognizant of it when reading other research and reports. As all of New Zealand discovered from the COVID-19 vaccination 90% target, what denominator you use can make a meaningful difference. Using the Ministry of Health Health Service user data set, got a population of 4.21 million. And using the Stats New Zealand denominator, the estimate was 4.36 million. And that was a census-based estimate. And you can see that makes a meaningful difference to the percentage of the population that's vaccinated and how close we are or were to the 90% target. So understanding the biases resulting from different denominator choices is obviously important. So in conclusion, the GCH identifies a different rural population and produces different rural-urban health outcome data than older, more generic classifications. Māori are more likely than non-Māori to reside in rural areas and live in socio-economically deprived rural areas. Oh, sorry, the timing's out of sync with this one. Mortality rates for those under 60 years of age are higher in rural areas and provincial cities than in the main centres, and the opposite is true for hospitalisation rates. Inequities between Māori and non-Māori within every level of the GCH is considerably greater than between urban and rural Māori. The excess all-cause and amenable mortality experienced by rural Māori compared to urban Māori suggests there are additional challenges associated with living rurally. And although the rural COVID-19 vaccination rates lagged behind the urban rates early in the rollout, Māori in the most remote areas actually had higher uptake than Māori in the most urban areas, and this was not the pattern observed for non-Māori, non-Pacific. We're looking, in terms of where to next, we're looking forward to getting to the results stage of research that's currently underway, as well as seeing findings from research that others are undertaking using the GCH. As most of you will be aware, New Zealand has just produced its first national rural health strategy, and this strategy has drawn heavily on the GCH and our findings in doing so. There's still a lack of rural-urban comparisons in primary care utilisation and a lack of data at regional and local levels, which is important as rural communities are very heterogeneous, including by socio-demographics and the determinants of health. There's an opportunity to use the GCH to monitor health outcomes and service utilisations at both a regional and a local level. And there's large variation in how rural healthcare is delivered across New Zealand, but to date, that has received very little evaluation or monitoring. So we think a consistent definition creates an opportunity to monitor these outcomes over time and to evaluate and better target interventions. Thank you. I'm happy to answer any questions now that anyone might have.
Thank you so much, Gabrielle. Well, excellent presentation and like a whirlwind sort of tour, isn't it?
Yeah, sorry, I know
various
there's
papers.
so much I could present, but
no, it's really useful, and I'm sure there'll be lots of questions. So Thomas has his hand up. Thomas, do you want to go first?
Okay, yeah, thank you. One question regarding your rurality measure. We certainly don't want to kind of go into the details there, but like, can you briefly say, does it include some kind of accessibility measure in terms of healthcare providers, or access to hospitals, or what is kind of the main difference to the other definitions of rurality that you also mentioned?
so the GCH is very similar to the way that the urban accessibility classification is designed, but it did include considerable consultation with communities across New Zealand, where they found that where they were given an opportunity to provide feedback on how well the urban accessibility classification made sense on the ground in their regions. So based on that, some of the cutoffs that were used in the urban accessibility classification were modified. So the main inputs for the urban accessibility classification are drive time to urban areas and the size of the population. So those cut points were modified to categorize areas into the GCH categories, but there were also particular areas that were exceptions, areas that those working in those particular geographies indicated, and with consultation with them, there was a couple of tweaks that didn't quite fit that were exceptions to the rules. For more detail than that, I suggest that you look at developing the GCH paper that Jessie led.
Relating to the last question, Steve York's asking, drive times assumes that people have cars and or access to public transport versus nil transport. Do you have any extra comment on that?
Just that yes, we did acknowledge that was an issue. I guess any classification isn't going to work for everyone. Yeah, so just acknowledge that as a limitation.
Yeah. Okay, so a question here too from Kim Dunstan. She says, this is very interesting. I have another meeting to attend to, so I'll come back to the recording. But where someone is living at the time of death is not necessarily where they live in their recent years. I think you've mentioned this somewhat, Gabrielle, let alone where they live most of their life. So what do we know about how migration might be confounding the analyses? Might there be a small effect for younger ages where exogenous causes are most important, but perhaps a bigger compounding effect for older ages where endogenous causes dominate?
So that is exactly what we want to be looking at as part of the current research that's underway, and not with migration as a confounding factor, but looking to understand those patterns. So we'll be in the IDI, we can obtain sort of a historical addresses as well, and so to be able to look, so that's why we're starting at the point of death and looking in the 5 years prior to look at whether someone has moved from an urban area to a rural area or vice versa, and trying to understand that and unpack that both by pattern and causes of death. When we're talking about rural residents, yeah, there is a big question, and we often discuss it in meetings too, about how you would classify someone when you're thinking about someone's lifespan as a rural resident versus, are there particular periods of your life that it's more important in terms of health outcomes as to whether you lived in a urban or a rural area? And that's an area that we have yet to even develop a sort of a funding application or to do more work in.
Laith Kyorji, how often, if you are you looking to update the GCH? Is that on the radar?
Yeah. And for some of these things, as June knows, with the NZ they are funding dependent. So like with the NZ in line with each census would be the ideal.
Yeah. Excellent. So this is for the most recent census, is it, that you're?
So no, what I've presented now is based on the 2018 census.
2018, yeah.
Yeah. We have yet to start any GCH 2023.
Yeah. Question from Li Feng Zhao. It's a great presentation, such a lot to digest. I would assume a cross-sectional approach has been adopted in some of the research. I wonder of a cohort approach where they'll be used in a future study to understand the full effect of the urban-rural, adjusting for other potential confounders. Thanks. Thank you.
Yes. I guess that would be analysis undertaken in the IDI. I guess so far that would be the only research that we've got undertaken using sort of the longitudinal approach is that looking at the migration. But I think that's a great idea to focus on that area as well in future.
Yeah.
Or that approach rather than an area.
Thanks, Gabrielle. Jason Arnold's question. Kia ora. I've heard previously that often people in rural areas may use PO boxes for their address. This means the geocoding of the address and health data may not locate them in an R2 or 3 area. Do you have any experience of this and how it's accounted for?
We do. So I've done a separate piece of work looking at that using that. I'm currently got reviewers' comments from a journal that I've submitted it to. So for that, we looked at using the mortality collection as the gold standard because conversations with the Ministry of Health have indicated that substantial recoding is undertaken in manual intervention to tidy up addresses that haven't geocoded properly. So using the mortality collection as the gold standard, we compared for those that died in hospital, the domicile and the GCH category, but recorded in the hospital discharge data and in the mortality collection. In terms of the results, I can't recall them off the top of my head, but there were some interesting patterns, and Jason, I suggest, and others, I'm happy to discuss those after the presentation or, in the coming days if you wish. And hopefully there'll be a publication out soon on that.
Steve York, to everyone, great presentation. In relation to the undercounting Māori research article, is IDI being used to quantify the undercounting numbers?
Andrea, you might be able to answer that. Can you answer that one better than me, or June, or others that are online?
I saw Mel present on this recently. I don't know if they've planned anymore, but June might be able to talk to that. And she knows of any additional plans on that work.
Not at the moment, I think. We'll just deal with what we've got. Yeah.
Yeah, but that's a really interesting question.
Barry here. I think the work on the administrative population census is trying to capture that. So it's out of the census transformation team at Stats New Zealand. Will
they look at the HSU specifically, Barry, or?
No, you have to do the comparison yourself, but they'd get the numbers that they think are of different ethnicities in New Zealand based on the across the IDI datasets, basically.
Yeah, to the best they can. Yeah.
Best they can, yeah.
Thanks, Barry, June and Andrea.
Thank you so much, Gabrielle, for your time today and presenting this work. I think it's really interesting to see what you can do with a standardized indicator. And I'm really interested in going back to that paper on that first question and looking at how the methods vary from the existing generalized rurality indicators. So yeah, thank you so much for your work, and yeah, I think everyone can join me in some virtual clapping or something for Gabrielle. But thank you so much. So we're not in a real lecture theatre, you can't hear all the noise, but we're very grateful for your efforts.
I can imagine. But also just
Thank you so much.
a big thanks to those for taking time out of their day, their lunch break, possibly to come and listen.